trained with additional training in oncology. So my day job consists of treating patients with what we call primary brain tumor, which happens in the brain or spine itself, or also helping and working with our medical oncology colleagues in treating patients who have either brain metastases or neurologic complications from their cancer or treatment. So obviously the chemotherapy-induced peripheral neuropathy is a huge part of the side effects. So I thought this might be a good topic to meet all of you and hopefully give some information that is helpful. So the three big questions that we're going to address is, the basic things. What is neuropathy and what causes it? We're going to obviously focus mostly on the chemotherapy portion of it, but we can also discuss some of the other risk factors which can add to the chemotherapy-induced neuropathy. Second question would be, how do you diagnose it? What is the workup? Lastly, probably the most interesting portion of it is what can we do to either prevent it or treat the symptoms. So generally talking about neuropathy, so simply just means that there is a dysfunction of the peripheral nerve. So neuro meaning nerves and pathy means there's something wrong with it. And then looking at the pictures, you could see that this brain, spine, as well as this peripheral nerves that feed into essentially every part of your body, and muscles that connect to the peripheral nerves make up what we call nervous system. So neuropathy is actually a very common neurological problem in general, and it definitely becomes more of an issue as people get older, almost like a wear and tear of the nerves that's been working very hard throughout our lives, and all the other risk factors. So, for example, diabetic neuropathy is actually one of the most common neurologic problems and pretty significant, pain and deficit that comes along with it. And a lot of what we know and tried in the chemotherapy-induced peripheral neuropathy, we are actually borrowing from the treatment of other neuropathies and testing it out and see if we can help the patients in the cancer system as well. So, the three most common problems that I see from the medical oncologist would be the chemotherapy-induced peripheral neuropathy, as well as cognitive memory problems, either related to chemotherapy or radiation, and brain metastases. So when we're talking about neuropathy, because it's such a big general term, we do have to add some descriptors to figure out what we're talking about. So we talk about sensory neuropathy, which means that the nerves that transmit sensation from your hands and feet into the brain, so your brain could recognize what's happening with your body, that those nerves are affected. So when those sensory nerves are affected, what the patients feel is generally that tingling, burning sensation in hands and feet, or numbness, depending on which nerves are being affected. So those are generally the most common symptoms that we hear about. There can be a motor neuropathy, so it actually affects the nerves that feed into the muscle and makes it move. So that would be felt as weakness. So you feel like you can't control your muscles, loss of dexterity in hands, so you feel clumsy, writing is more difficult, buttoning things is more difficult. So definitely can affect day-to-day living. More rarely, there is an autonomic nerve. So those are to be the nerves that we don't even think about. Something in the gut helping with the digestion or helping regulate your heart rate and blood pressure. So those can be a little more difficult to diagnose because it's pretty vague symptoms like just dizziness, lightheadedness, or feeling weak. So this is a little, picture slide that goes over what I just talked about. So the most common symptoms are on the left side, that's sensory nerve damage. So you get that unusual sensation. Sometimes you feel pain even from light touch, something that really should not be painful. And we call that allodynia. Burning, numbness, tingling is really the biggest complaint that I get. And balance problem can happen because you feel numb and you have difficulty telling where your kind of feet and hands are in space. Weakness is not as common, although Patient might feel like their legs are very heavy or their hands are very heavy. But when we do examine the patient and testing the muscle strength, generally what we see is that it's more of a sensation problem, but not weakness in the muscles. So as I mentioned, autonomic problems are rare, but you could see that it can present itself as kind of weird symptoms, excessive sweating, heat intolerance, just getting full quickly, and what we call orthostatic hypotension. So your blood pressure is supposed to go up when you stand up so you don't feel dizzy. But when your body's not able to control that, you feel lightheaded when you first stand up, or people can even pass out. All right, so before I kind of move on to, sorry, keep going back and forth, why these things are caused, how chemos are causing it. Any questions about what neuropathy is?
Yes. Can you hear me?
Yes, I can.
I have question. I have chemo many years ago, like 18 years ago, and I start, actually this is my first time hear about this thing, that chemo can affect like this neuropathy. So I start feeling this maybe in 5 years after my chemo. And it was first, it was very, slow. I even didn't know. It's like something bothering me in my toes, but I wasn't sure. And then it started progressing year after year. Then I start losing balance. And right now, I even cannot explain how awful it is. I was diagnosed with vertigo. I'm not sure, do I have it or not. I was falling for the stairs. It was different things. And is any way that it's possible to get some information more? Because, I never was able to read. And I went to the doctor. I didn't regularly. I talk to my physician. I talk to
Laura, I just want to be
oncologist.
mindful of the time. Is the question?
Okay, I'm sorry.
I think Dr. Nam will actually address your question in her presentation.
Yeah. So that's actually a pretty good segue. I'm sorry that you're having a lot of problems, but we're certainly going to talk about what's typical for chemotherapy-induced neuropathy. Just from hearing that little story, unfortunately, it sounds like it happened pretty far after your chemotherapy ended. Generally, what we would see is that these symptoms actually start to develop while you're on chemotherapy. So let me actually move on to the next slide. We're talking about it. So chemotherapy-induced peripheral neuropathy, CIPN, that obviously depends on which chemo agents are being used, what dose is being used, and duration as well. So as you could imagine, the higher the dose, the longer the duration, the more likely you're going to have that chemo-induced peripheral neuropathy. But unfortunately, majority of the patients suffer from some sort of CIPN, and then the rates that's being quoted is anywhere between 30 to 60%. I put a little asterisk next to it because that number varies pretty widely depending on when you measure it from the chemotherapy and what kind of rulers or measurements that you're using to define the peripheral neuropathy. So what people have used or the researchers have used to measure it would be just asking patients, do you have the symptoms of the burning, pain, numbness, etc.? Additional question may be, because of these problems, do you have problems doing your day-to-day activities like walking around or doing your buttons, getting dressed, or working? So obviously more people would have symptoms, but fewer patients will have actual problems because of the symptoms. But so what we've seen is that it's as high as kind of 60% when we're taking all comers in the first 3 months after the chemo, and things start to get better slowly after and decrease by about 50%, so down to 30% of the patient might have some symptoms when they're 6 months out from the chemo or more. So there is certainly some improvement with time, and that's unfortunately the biggest factor in treatment of the peripheral neuropathy. But chronic neuropathy is definitely a significant quality of life issue for cancer survivors. And what we would expect from the chemo-induced peripheral neuropathy is that they would start to show up as this, what we call symmetric distal stocking and glove. I put that in quotes. It's because you feel, essentially you feel like you're wearing stocking and glove. Those areas numb or just tender. And that's the typical picture that we would see. And the sensations are generally more affected than the strength. So the highest risk is in patients treated with platinum-based agent, taxanes, and Vinca Alkaloids. So those are kind of the three different chemo agents. It's difficult because these are the three that are pretty commonly used. And because these agents are used pretty heavily in treating patients with breast cancer and colon cancer patients, those cancer survivors are affected. Affected, and then there are a large number of patients with breast cancer and colon cancer. So certainly the number of patients with this problem is pretty high. Most of the research done on CIPN is in Taxol and oxaliplatin, and we're going to go into those agents a little more in detail in the next few slides. So, but this is not to say that if you're definitely get it if you are treated with the platinum-based agents or taxanes, or that you will never get it if you're on the lower risk chemo. So I think the biggest takeaway is that patient really should be appropriately counseled on the symptoms to look out for before you start the chemo. So you could, have that conversation with your team about, how bad are the symptoms? What are we going to do? Are there adjustments in the chemo or anything else that could be made to help prevent this from getting worse? So we're going to talk about the platinum-based chemotherapy. So those are the three drugs that are used: cisplatin, carboplatin, oxaliplatin. Oxaliplatin is probably the biggest troublemaker out of these three. It's platinum. So these chemos have this platinum molecule right in the middle, little PT there. And because it's sort of heavy metal base, it binds to the DNA and disrupt the DNA and kill cancer cells. So that's how they work, but it can also affect the neurons, which is the part that's carrying the sensation or sending the signal to the muscles. So oxaliplatin is known for its acute neurotoxicity, so the cold sensitivity, and that can happen up to 85% of the patient depending on the dose. So typical symptoms would include kind of discomfort swallowing cold items. So they do ask the patient to avoid drinking cold things while they're getting a few days after the infusion day and a few days after getting the oxaliplatin. They could also get throat discomfort, almost like spasms, muscle spasm, and then sensitivity to touching cold items, especially in hands. So you could get that kind of burning, tingling sensation in the hands, feet, as well as around the mouth. And this is pretty well known so hopefully everybody kind of knows what to expect when they get oxaliplatin. So these symptoms kind of peaks a couple of days after the infusion and improves over that first week. There is some mixed data whether it improves completely back to normal or there's some residual deficit, but definitely something to look out for. This is thought to be due to the problem with chelation of calcium. So something about oxaliplatin kind of takes away the calcium molecules briefly, leading to the nerves overfiring and then sending these weird signals and giving extra sensation that's not there. So you feel the sense pain and tingling when you're not doing anything. If it's a problem of calcium being taken away during the infusion, before or during oxaliplatin, then they'll fix the problem, and that actually has not been the case. Cisplatin is not as commonly used, but it can cause problems in hearing, so ototoxicity, so you get that ringing in the ear or hearing loss, so that should be monitored. Carboplatin is actually least neurotoxic, but the peripheral neuropathy can have a much lower rate. The unique thing about the platinum-based chemotherapy is that there's something called a coasting phenomenon, where this neuropathy can worsen even after you stop the chemo. And it may worsen over the next 2-3 months, even while you're not on chemotherapy, and then improve after that. So this can be pretty frustrating for patients and also the doctors. The next drugs group is Taxanes. So this is the paclitaxel. The brand name will be Taxol, as well as docetaxel or Taxotere. So those are the two main drugs. Taxols actually can have acute pain syndrome as well. Most of the other chemos, other than the oxaliplatin and Taxol, does not have the acute problem. It's mostly chronic. Taxane, how it works is that it prevents, so there's something called a microtubule in all the cells, and that's how you build bridges to carry things around in the cells. And Taxane kind of prevents it from disassembling, and then there's the thought that it disrupts the cellular transport in the neurons, and then that's how they affect the nerves and kill them. So the taxane-associated acute pain syndrome can be quite painful, severe kind of joint muscle pain, along with the numbness and tingling. And that also starts about 1 to 2 days after the treatment and can last median of about 4 to 5 days. Initially, this was thought to be due to musculoskeletal side effects, but now more people are thinking that this acute pain syndrome is a neuropathy or the problem with the nerves. Unfortunately, there's no kind of good effective treatment, but anecdotal data for trying some NSAIDs like Advil or some steroid like prednisone before and after the infusion with Taxol. Narcotics definitely do help with pain. There were a couple of different trials looking at different vitamin infusions like glutathione and glutamine and see if that would be helpful, and that was not effective. That's it. And for the chronic problems, approximately half of the patients who get this more, not the acute problem, the slow progressing numbness tingling problem, they would actually improve once the chemotherapy is discontinued or completed. And the Vinca Alkaloids are the last main group. And I don't think this one is used as often, but certainly we use it in kind of pediatric tumor, lymphomas, as well as some lung cancer. So we can see the symptoms happening. Vincristine kind of affects the same problem, prevents a microtubule formation and disrupts, transport just the way the taxanes do. And the vincristine is the biggest troublemaker out of the four. Sensory neuropathy is almost in 100% of the cases, just depends on the degree or degree of the severity. And the unique part about it is that it can also cause significant motor neuropathy. So patients can develop kind of like almost like a wrist drop or foot drop, where those specific muscles get very weak. And they can also get autonomic neuropathy. So constipation is very, very common with this drug. Some of the other ones that are kind of newer on the market, so we don't know as much about these, are epithelials, or Exempra would be one of the examples used in breast cancer. So those are second, used in patient, not newly diagnosed patient, but a patient who's had other chemos before. So they can also cause sensory neuropathy. Good thing seems to be that the symptoms typically resolve almost completely within 6 weeks after stopping the drug. And bortezomib is another one. Velcade is a brand name that can also cause predominantly sensory neuropathy. This is used in multiple myeloma. But some of this kind of more severe neuropathy caused by bortezomib seems to respond to immunotherapy like IVIG or steroids. Okay, I think this is another kind of good point to stop and take some questions.
Reminder to everyone, questions can be submitted through the chat feature, or you can unmute yourself to ask. Please focus on general questions and leave personal questions more towards the end of the program. Okay, we can continue, and if people have questions, just remember you can use the chat.
Yeah, all right. So kind of when we see patients with chemo kind of coming in with all these symptoms, what do we do? What's the next step in the evaluation, right? So as neurologist, the first thing I do is the history. So we're going to ask about timing of the symptom onset, like when did the tingling and numbness start to happen. So kind of going back to that first question that we had, I would expect if it's related to the chemotherapy to have happened while you're getting the chemo or shortly after. And then the pattern of symptoms, so this is what we see in terms of that glove stocking distribution. So you could see that feet are affected first because those are the longest nerves, and it just has more chance of being affected. And as the numbness and tingling travels up the leg, up to kind of the knee, that's when we start to see the hands being affected. So those would be kind of the pattern of the symptoms, and also on the examination that I would look for. Other things that we might do, especially if there is something unusual or does not fit with kind of what we know about the chemotherapy-induced peripheral neuropathy, whether there's a focality, like just one side is more symptomatic than others, I would probably check labs and maybe even do something called an EMG, so the nerve conduction study and electromyography, so testing the functions of the nerve and the muscles. So this would be kind of what I would look for on exam. I've certainly had patients who come in with kind of numbness and tingling in the hands, and they were told that they had chemotherapy-related neuropathy, and they actually had carpal tunnel. So that top left on the blue picture would be where I would see the numbness and tingling, or weakness for the carpal tunnel syndrome. So in those cases, we actually, if you confirm it with the nerve conduction study and EMG, you could go to the hand surgeon to get that released, and then people get pretty good relief from those symptoms. The bottom hand is actually, so basically the rest of the hand is supplied by something called the ulnar nerve, which comes through around your elbow. So again, if that's actually more of a problem, then we could fix that. And the legs, you hear about sciatica or the radiculopathy. So when you get the arthritis in your back and they get pinched nerves, that goes down the leg. So a lot of times patients would complain about the shooting pain down the leg, either in the front or the side. And then that can be pretty severe. So those would be the things that I would look for, because we would fix this very differently. So if these nerves are being pinched by either kind of the disc or just because of the arthritis, there are more procedures that could be done. And so this is just a little picture. That's what the nerve conduction study looks like. They use that little, like a handheld machine, to send a little stimulation, so a little shocks essentially, right over the nerve, and then see how they measure in the hand. So this will be checking for that carpal tunnel, so median nerve, which supplies the hand, goes right through that middle area. So by shocking the median nerve and measuring how the sensation in the thumb and then the rest of the hand, it gives us a good idea of how the nerve is functioning. All right. And the other thing that I usually look out for is other risk factors. So I mentioned in the very beginning that neuropathy is a very, very common problem, with or without cancer or without chemo. So diabetes with 2-star, that's really the most common risk factor for neuropathy. So if you do have history of diabetes or kind of even impaired glucose tolerance before you start chemo, you're more likely to unfortunately develop these symptoms because your nerves are already under stress. And older age, again, just because with an older age, you've had time to unfortunately accrue more problems like diabetes or liver kidney problems, as noted below. thyroid problems as well. So I check for hyper or hypothyroidism. If you have history of other autoimmune diseases like Sjogren's or lupus, that could also be part of the problem. We think that autoimmune diseases generally happen because there are extra antibodies against your body. And those same antibodies that's attacking, let's say, kidney or thyroid, that could also attack the nerves. Other toxins, so these are the part that's actually more fixable. Alcohol use, especially kind of chronic heavy alcohol use, definitely affects the nerves. Tobacco smoking is also a problem. So if I noticed heavy alcohol use or tobacco use, I certainly encourage patients to quit because I think it's going to help the nerves or the neuropathy from not getting worse. Liver and kidney disease can also do it just because liver and kidneys are the main organs for clearing all the toxins. So if they're not working, we're building up these extra toxins that we can't even generally measure. Vitamin deficiency is another big problem, especially vitamin kind of B as in boy factors. Most people who have good diet is not a problem. Some people with other medical problems can have it. So it's a pretty low-hanging fruit, and I'll send these labs. There are some other drugs that can cause neuropathy other than chemo, but those are pretty uncommon. So there are a couple hard drugs and kind of what we call immunotherapy drugs that can do it. But I'll review the medication list as well. So I like to look for other risk factors that can be optimized just so I could prevent kind of further worsening in addition to chemo-related neuropathy. All right. So in summary, in general, the chemotherapy-induced peripheral neuropathy should be symmetric. It affects hands and feet. It should be kind of in all of the limbs. If it's just on one side or the other, then we would look for more focal neuropathy that's being usually compressive. And then generally they progress slowly. If atypical features, as in that there's asymmetry, or if they're happening pretty quickly, kind of within like days to weeks, you definitely would need further workup looking for other causes. All right. So looking at, I see some of the questions that's come through, and then I'll try to address them. The first one is, what cancer types have the oxaliplatin as at the PT? I'm not sure kind of which cancer types used oxaliplatin as a part of the treatment. Is that the question?
That is it.
Okay. So the oxaliplatin is very commonly used in colon cancer treatment. So the kind of the two main regimen use that as one of the first line treatments. So colon cancer is the most common one. The second one, why won't oncologists talk about peripheral neuropathy? Most worried about, and then end up being the only side effect. So I think the really difficult part about this is we don't know who's going to develop peripheral neuropathy. So obviously the numbers are high, and I do believe that we should talk about it before kind of every single case. But when we're talking about like the colon cancer patients or breast cancer patient, a lot of the early diagnosed patients, we are talking about curative chemotherapy regimen. So we're really trying to balance it against, giving you, unfortunately, kind of harsh but best regimen upfront, and then balancing against possibility of the side effect. I really hope that like more research comes along, that we could look at who are the patients that are most at risk and what are some of the preventative regimen that we could use. But certainly we don't want to withhold chemotherapy that could be curative just because we're afraid of possible peripheral neuropathy too. But yeah, no, it's a really tough position. And then it's probably the decision that we need to make together as a team, right? Between the oncologist and the patient as well. Let's see, some neuropathy and finger, took drug for pneumonia. anything worse? Yeah, okay. So I'm going to address that a little bit when we talk about the prevention. I think if it's something that was there before and remained same, maybe, I think it might be worthwhile getting evaluated by a neurologist, which I think is one of the next question too. So neurologist, neuro-oncologist, they can evaluate for the neuropathy. Carpal tunnel, if it's more of a carpal tunnel, I don't suspect that it's necessarily going to get worse from the chemo, that part. You might get kind of the chemotherapy-induced neuropathy on top of the carpal tunnel. And if it is a carpal tunnel, generally the conservative treatment would be splint. So carpal tunnel happens because we're pinching the nerve in the wrist when we bend the wrist back and forth. So especially with now everybody has their smartphone or computer, and then we kind of bend our wrist to like type with my thumb and things like that. So those are the part that certainly makes it worse. And people also sleep pretty scrunched up. So a lot of times people will wake up with like numbness and tingling in their hands, and they kind of shake it out and it gets better. So wearing a splint at night or even during the day to keep that wrist straight, that could be helpful. Just kind of speaking in general. If that's not conservative management is not helping enough, surgery to release that nerve from being compressed, essentially, that can be done. So it's either done by kind of like ortho hand surgeons. So I think evaluation either through your primary care physician or neurologist would be helpful. Oh, let me see. And I think we answered some of these. Is the trigger finger related to chemoneuropathy? I don't believe that is. Do some cancers actually promote neuropathy more than the chemo? And the short answer is yes. So I think I mentioned very briefly multiple myeloma in the beginning. So multiple myeloma is a cancer of the immune cells that actually make antibodies. So normally we would make this like X level of antibody that is good for the body. We don't have extras around. When we have a cancer in these cells and they grow uncontrolled, we have extra antibodies, and those things can affect the nerves and actually other organs as well and cause problems. So neuropathy can be almost part of presenting symptoms for multiple myeloma. So that would be one of the cases where cancer is promoting the neuropathy more than the chemo. So next question about the nerve damage has gotten worse over time. It was on the left hand, gotten worse over 2 years, going up the leg. Generally, with the chemotherapy-induced neuropathy, once the chemo is done, it shouldn't be getting worse over kind of years and years and years. It will be more static or the same. So if it's kind of like the going up the legs or shooting pain up and down the legs, again, I may recommend that you evaluate it by like a neurologist or even starting with a primary care physician to see if there could be other causes that could be causing the problem, not just the chemo. And okay, all right. So and then the rest of the question, I think I'm gonna answer in the next slides because we're gonna be talking about treatment and prevention. So I might move on to the next section, if that's okay, or if there are more questions about kind of what neuropathies are so far, or the diagnosis. Okay. All right, so as I was kind of putting this together, ASCO, which is American Society of Clinical Oncologists, they just put out recommendations on the prevention and treatment of chemotherapy-induced peripheral neuropathy. So this was actually published 2 weeks ago, so fresh off the press. So talking about treatment first, the short answer is there's one agent that's been proven to help with the pain from the peripheral neuropathy, and that's duloxetine or Cymbalta. So when I will kind of go back and put a huge caveat to all of these, is that the peripheral neuropathy, it's pretty difficult to do clinical trial or interpret the data from different clinical trials because, as I mentioned, that there are so many different ways of measuring peripheral neuropathy. So we could just ask the patients to fill out a couple questionnaires that says, how bad is your pain? Where is it? You know, do you have difficulty doing X, Y, Z because of this? Or you could do more of an objective data, which would be doing something like a nerve conduction study, which can be pretty invasive, or with an examination, seeing kind of where the numbness is, how bad it is, reflexes, etc. So it tends to be that when you base the clinical trial purely on the questionnaires and patient-reported symptoms, there are a lot more benefit than when we actually measure things. So duloxetine is the only medication so far that's been proven to help with the painful neuropathy and maybe even with the sensation of the numbness, which I feel like is actually more difficult to treat. And it should be the first-line agent that is offered to treat the neuropathy, the symptoms of the neuropathy. So we're talking about pharmacologic agents. So we're going to talk about the pills first, and then we'll talk about, you know, other options that people have tried. So these other kind of number 2, 3, 4 are the agents that we had tried to borrow from other painful neuropathies like diabetic neuropathy. So gabapentin, which is Neurontin, and pregabalin, which is Lyrica. Those work actually very well in patients with diabetic neuropathy and controlling the pain. So with, you know, we thought that it would be a great idea to test it out, see if it's helpful in patients with chemotherapy-induced peripheral neuropathy. Unfortunately, that data has not been as amazing. It does seem like there are some group of patients where it is helped, but the sample size and how helpful it is not as impressive as duloxetine. So maybe, you know, I would use it as a second line if the Cymbalta didn't work. Amitriptyline, nortriptyline, these are called tricyclics, kind of old antidepressant, but really, really good drugs in modulating pain. In neurology, we use it a lot for neuropathies as well as headaches. So this can be a good agent to use. The side effect profile can be pretty bothersome, which is kind of the sedation. So it makes people pretty sleepy. I have the patient, if I prescribe it, I have the patients take it at night and actually take advantage of the sedation part. It can also be slightly anticholinergic, so constipation and some urinary retention. Maybe some confusion can happen. But when I start it on low doses and titrate it slowly, I don't see, knock on wood, I don't tend to see a lot of that problem. Topical gel, so it has mixed data, and that actually may be due to the fact that not this topical gel is the same. Like everybody has a different formulation and different drugs that they put into it. So, but the biggest issue is it can be expensive because it needs to be specifically compounded. But some of my patients have found it very, very helpful, especially when they get a lot of side effect from pills because it's topical and it doesn't have systemic side effect. So you just kind of put it on the area that is painful and it helps numb the area. And then you can only use it when you need it instead of taking something every day. So non-pharmacologic agents, so non-drugs, exercise, yoga, physical therapy actually seem to be helpful. So there's not strong evidence behind it, but definitely at least small trials are showing benefit in controlling the pain and also improving the function, meaning that you actually like move better. So I'm a huge fan of exercise and keeping active during treatment. As much as possible. So I feel like this is very low risk and high reward. And it can be done with any, they've tested it with different kind of exercise programs. So strengthening programs seem to be helpful, same with the balancing, even aerobic exercises. I think they said that heart rate at kind of like 40 to 60% of max. So not like very strenuous, but moderate aerobic exercises all seem to help patients with, certainly with their pain and then certainly with their function. The next one is a little bit interesting, scrambler therapy. So you essentially stimulate nerves around the painful area, and that helps, quote unquote, scramble the pain signal going into your brain so you don't sense it anymore. There are some mixed results. One trial actually showed benefit, but this was the one without kind of like a sham device, so it could have been some placebo effect. Other trial with a sham device where they kind of like pretended to stimulate the nerves, but they weren't in the correct area, didn't show benefit. So everybody felt better. So probably need to look at it a little bit more. It's not something you could kind of like buy to use on your own. It's a big device. I think they usually use it in like clinics. So not something that's available to patients, but hopefully if there's more research being done, then we'll see if it's good. Acupuncture also similarly mixed data as number 2. So it seems to help, it basically seems to help everybody, but is it actually because of the acupuncture, or people kind of just feel better because something is being done? Again, but this is also pretty low risk. So patients who have difficulty either tolerating meds or have significant pain even after will try it. And working with kind of like integrative medicine or integrative centers that's associated with cancer groups and then know these patient group can be, I think, more helpful. Let me answer a couple of the questions about the topical gel. So there is not a name, there isn't a name for it. It's a prescription only, and it has to be sent to a compound pharmacy. So that's usually some combination of amitriptyline, ketamine, baclofen, and maybe some lidocaine. So again, the formulation that people use is different from doctor to doctor. And then unfortunately nothing that's kind of been proven to specifically help with like carboplatin-induced or paclitaxel. One thing that's kind of over the counter and I have had patients try is capsaicin creams. That's another topical. It's not necessarily kind of recommended by ASCO, but again, may be beneficial and pretty low risk. And in terms of the massage therapy, I think that can be helpful from the treatment of pain, certainly. And best remedy for numbness. Oof. Numbness is difficult to treat. So I kind of mentioned in the beginning, the pain is almost easier to treat. So let's see, pain. So how I would describe it is that painful sensation, that extra sensation is your nerves firing when it's not supposed to. So we have medication to calm down the firing, which are the ones that I just mentioned. If it's numb and the nerves are not firing, we don't really have as many drugs to wake it up and start firing, unfortunately. So in terms of the duloxetine actually seems to help with the numbness a little bit. So I would try that. If we are having issues with kind of balance or walking because of numbness, I think physical therapy is more helpful in gaining some of that function back. So that was that was a treatment. Let me see if there's any other questions that I can answer.
In the event that anyone has not tried yoga yet, it's good for pretty much everything. Please try it.
Agreed. Let's see. And yes, I think acupuncture can be definitely helpful. So trying it out at least for a few sessions and see if you personally get benefit is worthwhile, but not something that you necessarily have to continue if you're not noticing any improvement in the beginning. Okay. So hopefully that maybe answered the question about the alternatives you can do for neuropathy instead of just taking the pill. And then, yes, the Voltaren gel can be helpful as well. So that's basically NSAID. So not like something similar to Advil in a gel form. And don't quote me on this, but I feel like it may be becoming over the counter. So it's used a lot for patients with knee pain, arthritis, and I think it can be helpful too. All right. So next, we're gonna move on to, getting close to the time, sorry. We're gonna go into the prevention. So the short answer is, unfortunately, no medication has been proven to help prevent the neuropathy from happening completely. Couple of things we do know, and this is the part that I kind of want to bring up, is that some supplements, so like acetyl L-carnitine, I know we feel like some vitamins and supplements, they should be pretty safe, it's natural, but they can worsen neuropathy. So we didn't know it. We thought actually it was a good idea. So when I say we, I mean kind of like the oncologists as a group, not me personally. But so we tested acetyl-L-carnitine to see if that would actually prevent the neuropathy. And then the patient who got this supplement actually had worse neuropathy compared to the people who had placebo during chemo treatment. So that's why I don't feel completely comfortable saying like go ahead and take all the supplements you can. I'll try to give kind of all the evidence or the information that we have, but definitely don't take the acetyl-L-carnitine. Some promising trials coming along in the last few years is, firstly, is again exercise therapy. So I think it's good for preventing it. It's good for treating it. We should be keeping active as much as we can. And the other part that's a little interesting is a cryotherapy or compression therapy. So if you guys are aware of, the cold caps for preventing hair loss. So kind of similar to the idea behind the cold cap. So you keep your hands and feet cold while you're getting chemo. So far, it's been kind of the small trials, a lot of it kind of looking at whether or not if it's feasible or tolerable. So there has been kind of half of the trials that patients did fine. Nobody dropped out. The other half said more than half dropped out because it was painful and it was too cold. So probably something that we need to look at. There does seem to be maybe some benefit to it. And frozen gloves seem to work better or better tolerated, at least, than just holding plain ice packs. Compression therapy is a similar thing. You actually wear like gloves that are too tight. Idea is that kind of preventing more of the blood from flowing to the area. So something that I will probably keep an eye on and see what happens in the next few years. And the next one, this is very interesting, ganglioside monosialic acid. So it's a drug. There were 2 small trials. One I think was US, and then the other one was actually in China. One of them showed benefit. Actually, both of them showed benefit. One showed more benefit than other. But the second one that looked really impressive, but also had complete reversal of all neuropathy in the patient who had placebo. So just a very unusual data. But again, some drug to keep an eye on. I'll be interested to see if we get more data out of it and something that we could use to prevent the neuropathy from happening. The last one is duloxetine is actually being tested for prevention of the chemotherapy-induced peripheral neuropathy, specifically with oxaliplatin. So hopefully we will have the results probably in a few years, but it's good that we have these large trials happening. So some maybes, there's a nutraceutical, so kind of supplement called L-carnosine, small trial that actually looked pretty impressive. So 61% of the patient who didn't get L-carnosine got neuropathy, but only 3% of the patient who got it got neuropathy. But again, this was I think 50 patients, so very small trial, definitely needs more data. Kalmangafodipir, I'm not sure if I'm pronouncing it correctly, but they didn't see any difference in objective data when they kind of on the examination, but patient felt like their pain and symptoms were better. So that was enough to move into the phase 3 trial, which is ongoing in Europe right now. Something that's kind of a little easier to use would be omega-3 acid. There was a small trial looking at it, but they asked the patients to take it 3 times a day, which is a lot. That did decrease the percentage of the patient who developed neuropathy by about half, 30% as opposed to 60%. But people who did end up developing neuropathy had the same level of symptoms, so it wasn't any better. Metformin, which is a drug for diabetes, small trial, again, about 40 patients, maybe a little bit better as well. So this is a drug that I think that's worth looking at because it's cheap and we use it very often. And if it's something that could be added without significant side effect, that would be good. And again, the last couple, acupuncture, lipoic acid, vitamin D, all unfortunately the data isn't great. So again, with an acupuncture, when they did it during chemotherapy, the neuropathy symptoms were similar in patient who got acupuncture and didn't get acupuncture. And then the patient who got acupuncture actually had a slower recovery from the neuropathy. So I would probably try it for treatment of pain rather than trying to use it for prevention. Alpha lipoic acid is another one that there's some data that it helps in preventing the worsening of the diabetic neuropathy. So that was tried in patients who's undergoing chemo, but only about 30% of the patients were able to actually finish taking it, either because of the side effect or it was just too difficult, and then we didn't see any difference. And vitamin B, again, very small trials, not clear data, so I'm not sure if it's going to end up being a good drug or not. We just don't have enough numbers to say. Some that we know definitely don't work, so calcium, magnesium, and then these other drugs, it's been tried in kind of a couple of different large trials and not helpful. So these are the ones that I would actually actively discourage from starting. So that was actually the end of the talk. Let me look at a couple of other questions. You keep talking about neuropathy during treatment. What about prolonged neuropathy? Yeah, 6 to 12 months after. So yeah, so that's the chronic neuropathy, and that can happen that's what I was mentioning, up to 30% of the patients. So about up to 60% of the patient would have some sort of neuropathy that 3 months after the chemo is done. So that's when we see actually during and about 3 months after the chemo, that's when we see the highest rate of neuropathy. And that can improve over kind of months. So by 6 months, 12 months, that number goes down to about 30%. But if you still have the symptoms kind of that far out from the chemotherapy, I think probably very low chance that things are going to improve after. So that's at that point we talk about managing the symptoms. So if it's painful, duloxetine, as I mentioned, is the first go-to. If that's been tried and not helpful, there are other medications that I would try as I listed. And yeah, so the ice pack, ice gloves and ice pack, oh, that's great that that's being used. And yeah, I think if you could tolerate it and it's not giving a lot of pain during chemo, like an infusion, I think, not a lot to lose. Restless leg after chemo, so that would be very, very different. I mean, so it would depend on what you mean by restless kind of foot syndrome. So sometimes patients, because of the neuropathy pain or numbness, kind of feel like they have to move it all the time. So in those cases, by treating the neuropathy, some of those symptoms get better. There's also kind of the restless leg syndrome that is separate from the neuropathy, that are like a diagnosis in and of itself, and then the treatment for that would be different. So in those cases, I think the best thing is getting actually like an in-person evaluation, either by a neurologist or even, again, primary care doctors. They could handle some of the beginning portion, and if they can't, they should refer out to a neurology team. And then you might have to try different drugs and see which one helps more than the other one. Sorry, things are moving. So sorry. Neuropathy in the right thumb, right forearm for myeloma due to melphalan. Oh, that's a good question. Again, if it sounds, sorry, I'm looking at Ed's question. So for looking at your question, that sounds a little more focal. So I would look at some other things that could happen other than just the drug. So if it's melphalan is another one of the drugs along, treatment of myeloma that can cause neuropathy. I didn't mention it because it's not something that a lot of people see, but if it was that, I would expect the kind of the neuropathy in sort of both hands, feet, as well as opposed just to one side. So it would depend on kind of the where the catheter was and everything, but it's a possibility. And how would I know if neuropathy is caused by chemo many years ago or being a diabetic? I would probably look at the timing of when the neuropathy symptoms started to happen. So it's certainly possible that patients have the chemotherapy-induced neuropathy from having had the chemo. So they have sort of the mild chronic symptoms after the chemo is done. Doesn't bother them too much. But a few years after, start getting worsening symptoms. In those cases, instead of just blaming on the chemo, I would look for additional causes that could cause neuropathy, like diabetes, thyroid problems,